you very much, Jennifer. I can promise you I will not be running 21 miles, but I will try to get my badge on so I can win that prize. It's a great pleasure to open session 5 of the CCF 2022, Thinking Big, Transformative Approaches to Cure Cholangiocarcinoma. Well, we haven't fully cured COVID-19, so most of the session will be live streamed, but it's some fantastic scientists and clinicians that are going to be in the session. And we're also very lucky to have Rocio Macias from University of Salamanca, please come up here to moderate the session together with Chiara Braconi from Glasgow University. So get all your questions ready.
Hello, everyone. It's my pleasure to be here face-to-face for the first time and moderate this session with my colleague and friend, Dr. Chiara Braconi. The organizers of this conference have prepared a great session to start today with 3 fantastic speakers. Even if they are online, you are going to enjoy it, I'm sure. The first speaker needs no introduction here. Professor Juan Valle is a professor of medical oncology in the University of Manchester, UK. He's based at the Christie NHS Foundation Trust within the gastrointestinal disease group. And the title of his talk today is Transformative Approaches to Clinical Trial Design. Please, Juan, when you want.
Go full screen.
Thank you very much, Rocio, and thank you, Chiara, for chairing the session. And I'd like to thank the Program Organizing Committee for inviting me to talk on clinical trials, which many of you know has been the cornerstone of what I've been doing for the last 20 plus years or so. These are my disclosures. And so I just want to start off with the publication track record over the last 70 years. On the left graph, you will see the number of any types of publications. You can see the blue curve is rapidly going up. That's actually colorectal cancer. If you look for the much smaller red curve on the left, that's in fact that's the publications for biliary tract cancer. And it is important to see that number gradually increasing, but you can see that partly due to the rarity, partly due to the challenges of identifying these patients, we certainly lag behind. On the right, you see clinical trial-related publications, and again in green is colorectal cancer, and the small bars at the bottom in yellow are biliary tract cancer. So I think we are definitely seeing...
Juan, I'm sorry, we are not seeing your presentation.
Okay.
Now, yes. Maybe you can share the complete screen.
Let me just start again. Can you see it now?
Yeah. Now, yes. Yes.
Is it on the slide?
It's in the presentation format, but we can see it.
Okay, hold on. Let me just try again. Excuse me. Forgive me, let me just... Okay. Is it visible now?
Yeah, it's in presentation format, but I think we can follow everything. Yeah.
Let me just...
Perfect now. Yeah. Thank you.
Thank you very much, and apologies. Still learning how to use the technology after all this time. Just to quickly, hopefully you were able to see that key messages, publications and clinical trial related publications are increasing, but you can see here that biliary tract cancer lags way behind a much more common cancer in terms of colorectal cancer. So where has that brought us? Well, I think this is where we were at the last guidelines in ESMO 2016 for patients with early stage disease, of course, surgery, and there wasn't yet a hard and fast evidence regarding adjuvant chemotherapy. And for patients with more advanced disease, systemic chemotherapy with otherwise very limited treatment options. These guidelines are currently being updated, and I think we can draw a line through the second-line chemotherapy. We can also probably draw a line across targeted therapy with no standard of care, because we have quite a few things to update this time round. We now have the use of adjuvant capecitabine to reduce a disease relapse after surgery. We have some second-line chemotherapy options in terms of FOLFOX and 5-FU and irinotecan. And you will have heard a lot of this meeting about the targeted therapies as standard, of course, in selected molecularly driven subset of patients. Dr. O yesterday presented the results of the TOPAZ-1 study, and again, immunotherapy is something that will appear in the updated guidelines. Now, just to quickly focus, how have these changed treatment? In general, they have been as a result of phase 3 studies. You can see here all of these, the evidence base is phase 3 for adjuvant treatment, for first-line treatment, second-line treatment. There's a couple of studies. 2B means a randomized phase 2 study, and the targeted therapy studies are in phase 2. And we know that with phase 2, we've now got some new treatment options. So for those of you who are not familiar with the clinical trial approval, let me just quickly take you through this. In phase 1, we're talking about relatively small patient numbers, and we're really just looking at the first step in testing a new cancer treatment. So we want to identify what's the right dose to give and what are the possible side effects, what's the safety for these patients. Once we've got the right dose, we then move into phase 2, and now we're talking a larger number of patients, and we want to see how effective that treatment is for a particular type of cancer. So we now narrow it down to an individual cancer. And then, of course, we go into phase 3 studies, which are the larger randomized studies, which are comparing the new treatment against current standard of care. And these are much, much larger studies. And at that point, then very often is when we get approval of a new drug. But can we stop at phase 2? So I want you to just imagine T1 is treatment 1 or therapy 1, and we've got some readout from phase 2 that it looks promising. We then go into a randomized phase 3 study and compare it against control, the letter C. And sometimes at the end of that study, we'll find a new treatment and that warrants being taken forward. Other times, we have to remain with the control arm and look for a new treatment. Treatment 2, therapy 2, may not give a very good signal, so we don't go on to a randomized trial. And this is how rather slowly and laboriously we have traditionally been developing drugs. So we get a new treatment, randomized trial, another treatment, another randomized trial. And you can see here that within the randomized trials, a lot of patients are receiving the control arm or the standard of care treatment. Now, we know that we have approvals for pemigatinib and infigratinib, and currently they're based on these phase 2 studies, which have shown very promising results with durable responses, disease stabilization, and very few patients having disease progression. But we need to be careful. Recently in oncology, we have had our fingers burnt. This is not a cholangiocarcinoma study. This is one in soft tissue sarcoma. There was a promising randomized phase 2 study of a new treatment called olaratumab, and this was added to doxorubicin and compared to doxorubicin, which is a type of chemotherapy. The progression-free survival was a bit better, but you can see here that the overall survival looked a lot better. And in fact, when it came to the phase 3 study, there was no difference in overall survival. And this is not the first study. There are 22 other examples given on the FDA website of studies that looked promising in phase 2, but that didn't progress because of a negative phase 3 study. So how does this apply to cholangiocarcinoma? Well, we know that selected patient subgroups may have a different biological behavior. So for example, FGFR2 fusion positive patients or IDH1 mutated patients, do they naturally have a better biology or a worse biology? So in order to really understand the results, we need some kind of context, we need some comparison. But the question then is, does it have to be a phase 3 study? Currently, drugs receiving accelerated approval still need to demonstrate a benefit in subsequent randomized phase 3 study. So can we be more efficient? This is a study called the Stampede Study. And here, the number of patients being treated in the control arm is minimized. The control arm is arm A, and this runs across a number of years. But rather than stopping and starting, multiple comparisons are made. So when the study started off, there were 6 arms, all of which were then being compared against the standard of care arm. But as an arm came to a close, new arms could be opened, new treatments could be tested, while the control arm continued to run in the background. This was very efficient in that it maximized the number of patients receiving a new treatment approach, but also allowed comparison with contemporaneous patients who were then receiving a standard of care arm. So this is the multi-arm type approach. This means that you can really get as much information from the patients taking part in the program. And we're thinking along the lines of something very similar in the Sapphire ABC10 study, which is an international collaborative study between France, the UK, and Belgium. This has currently received funding from the charitable organizations in all 3 countries. And it means that we'll be starting off with 800 patients willing to participate in a clinical trial. And then, I'm not going to go through this in great detail, but in patients who do have a molecular alteration, the core protocol is randomizing patients after induction chemotherapy to either continuing the chemotherapy or have a maintenance molecular targeted therapy. But we know that some patients will not have a targetable alteration, so there will be a maintenance protocol looking at regorafenib and PD-1 inhibitor. And for patients who have disease progression after the first induction chemotherapy, they can go on to second-line chemotherapy questions. So again, we're trying to be very efficient, understanding that patients are very rare and particularly fit enough to go into clinical trials. So pragmatic trials is the other thing to consider. And this was defined some time ago, and this was a paper in the New England Journal of Medicine in 2016, defined as trials which inform a clinical or policy decision by providing evidence for adoption of the intervention into real-world clinical practice. And colleagues in Canada have had a look at how this can be applied in, for example, breast cancer. And what they've decided is that you can go through a process of identifying clinically relevant questions, and you can do this by surveys of patients and other end users, and identify areas where there is clinical equipoise. In other words, we don't know what the best treatment is going to be. So you find out where the clinical equipoise exists, but more importantly, involve patients in a survey to identify important clinical endpoints. If there is clinical endpoint, equipoise, perform a systematic review, design a pragmatic trial, get consent, which hopefully is simplified, a rapid ethics review, simplify web-based randomization, collection of real-time data, feedback to the team, and include things like economic evaluation and knowledge mobilization. And just to give you a quick example of what they did in breast cancer, one of the questions that they were asking is, in patients who have had treatment with chemotherapy, some centers were using GCSF to reduce the risk of neutropenia and infection. Other centers were using an antibiotic to find out what the best way forward was. There's actually to do this pragmatic trial where there was randomization in the clinic to either GCSF or antibiotic, and then you collect your outcome data. And at the end of it, there's also a patient satisfaction survey. How can we apply this to biliary tract cancer? So there are some rather pragmatic questions that we still don't have the answers to. There's been discussion in the past as to whether gemcitabine and oxaliplatin is better or worse to cisplatin gemcitabine. Should we give treatment for 6 months or going through until disease progression, so a duration of treatment? In the second line setting, we now have 2 treatment options, FOLFOX and FOLFIRI. Which one is going to be the better option? So some of these questions could potentially be answered by pragmatic trials. The other approach is of using synthetic controls. So if you think about treatment in the blue box, what we'd like to do is to be able to compare the outcomes of that treatment with a control that is as similar as possible in terms of all the features we know are important for an individual cancer. Now, traditionally, that's been done through a randomization in a clinical trial with a control arm, but it may be that by building very detailed external databases, we would be able to select patients who match exactly the patients who receive the treatment within a clinical trial to then get a gauge of the degree of benefit. And I think in that respect, the important thing going forward is to make sure that we're expanding and building clinically annotated data sets, not just with clinical information, but increasingly some of the important molecular information that we need in order to understand patient outcomes. And in that respect, we have some established groups like the European Network for the Study of Cholangiocarcinoma, ESCALON in South America, which is primarily focusing on gallbladder as well as biliary tract cancer. And you'll hear later on this afternoon regarding the International Cholangiocarcinoma Prospective Registry from Dr. Shishir Maitel. And I think these are really going to be a very useful resource going forward. Finally, I wanted to just reflect to you how far we have already come in cholangiocarcinoma, and largely led by Cholangiocarcinoma Foundation in the US and the AMMF in the UK. This is from a New England paper in 2017 and highlighted the importance of working together across academic medical institutions, industry, federal agencies, as well as disease-focused foundations. And the exemplar that was used in this paper was actually myeloma, but you can see here that it really would apply to cholangiocarcinoma. So we have already academic medical institutions who can partner with clinical trial design, identify correlative studies, including the very important biomarker studies, and you'll hear from this in the next 2 speakers, have clinical input on the context of trial results, very much working together with industry partners. But I think importantly, nothing is going to move forward without having regulatory on board to try and make sure that the results of any data that we're deriving is meaningful, but also acceptable to regulatory authorities. With that in mind, I think CCF and AMF in the UK have really done a lot to bring together the stakeholders and supporting some of the efforts needed to make this a successful venture. The other thing, apart from me not being able to work my Zoom very well, we have moved towards going to electronic recording of information, telephone consultations, Zoom consultations, and it may be that we can make things easier for patients by collecting electronic patient-reported outcomes, which can be done at home, on a telephone, or an app. So I think we need to be thinking across the whole spectrum of how we can make clinical trials easier, not just for clinicians, but also for patients. In that very brief run through, I hope I've been able to show you that traditional trials have established a number of standards of care, but progress, I think we all feel the frustration is too slow. Rare cancers do present a very specific challenge, and small subgroups of rare cancers pose an even greater challenge. The interpretation of phase 2 data certainly requires context. Currently, that's in the form of phase 3 trials, but maybe we should be thinking about different ways of doing it and looking at synthetic controls, for example. Pragmatic trials offer a new opportunity worth considering going forward. And of course, we need to work very closely with regulatory and industry, but always ensuring that this is a patient-centered approach. Thank you very much for your attention.
Thank you very much, Juan. That was a great presentation for giving us some food for thoughts about how we can move ahead in terms of clinical trials. I would like to take this moment to introduce myself and just to say hello to everyone. I'm sorry I'm not in Salt Lake City, but as we are seeing, we are able to enjoy the conference very much from here. So we now can move on to the second speaker, and we will take all the questions at the end. Dr. Foda is joining us from Johns Hopkins, working as a gastroenterologist, and he will present us today a discussion about the role of ctDNA in biliary tract cancers.
Thank you. Good morning. Let me just share my screen. And we should be okay. Thank you for waking up this morning, Salt Lake City time, to come listen to my talk, and thank you to the organizers for putting on a great conference. So in my brief time, I will be discussing the role of ctDNA in promoting the cure for cholangiocarcinoma. Just to begin, I have no conflicts of interest relevant to this talk. As with most cancers, early detection is incredibly important for treatment and moving towards a cure. This is because the survival rates for any cancers, but specifically cholangiocarcinoma, is greatly reduced if it's not caught early. For cholangiocarcinoma, unfortunately, more than half of patients present when surgery is not an option. And as we know, surgery is currently one of the best treatment options. And so you can see on the right here, survival can actually decrease almost at least tenfold, specifically for intrahepatic cholangiocarcinoma, if we do not detect it or diagnose it at a localized stage versus a distant stage. There's a similar drop in survival for extrahepatic carcinoma. So this leads us to really need to figure out how we can detect cholangiocarcinoma earlier, and in order for us to treat it better with current and future treatments. So, however, the idea of early detection is very difficult, actually, with cancers in general and with cholangiocarcinoma. Some of the difficulties come from the lack of symptoms at the beginning, and some of the difficulties come with the issues with the current methods we have. So current methods of detection or diagnosis of cholangiocarcinoma include imaging techniques like CT or MRI, as well as invasive procedures, including ERCPs with brushing. Unfortunately, none of these procedures have great sensitivity. Imaging also can have poor specificity. Even the invasive procedures of ERCP, the biliary brushing has poor sensitivity. So overall, there's a need for improved detection methods. So that leads us to what the focus of this talk is today. And that is something that I'll refer to as liquid biopsy, but it also, so I'll describe what that is. So in this context, a liquid biopsy I'll be referring to as a detection of DNA in the blood of a patient in order to diagnose or track a disease, specifically in this case, cancer. As you can see from the schematic, cell-free DNA enters the blood either from blood cells or from tumor cells, or from some other normal cells where there's turnover, and it enters the blood. We are able to then draw this blood and purify out the cell-free DNA and use this for analysis or detection of the abnormalities in the patient's blood. Advances in liquid biopsy analysis, including whole gene, including next generation sequencing and some bioinformatic techniques, have allowed for these to be used for detection of cancer, as well as some disease tracking. The majority of the current methods and the original methods were based on mutations in circulating DNA. So as we know, cancers, tumors have a large burden of mutation compared to normal tissue. And therefore, it seems like a reasonable place to try to detect what is tumor DNA versus non-tumor DNA in the blood. Unfortunately, this leads us to, there are some issues with only using mutations. This is because of the 10 billion DNA molecules you could have in your blood in a patient with cancer. Unfortunately, only 100 million of these molecules, 2 orders of magnitude, is actually from the tumor, and only about 100,000 of these actually have the mutations that would be seen in these tumors. That is because tumors are heterogeneous in their mutations, and just the number of molecules that you see in the blood doesn't exactly correlate to mutation fraction. So this creates a really needle in a haystack problem of trying to find mutations amongst all the cell-free DNA in the blood. And this is to show you just the numbers that we're seeing. If we take a look at the fraction of tumor-derived molecules, so that's how much of the cell-free DNA is actually coming from tumors, and the probability of detection, the number of alterations, so the things we're looking at really determine how likely we're able to find any sort of changes. So on the right here, if we're looking for a single mutation, it takes us up to having 1% of the total cell-free DNA to be tumor-derived for us to be pretty certain. But as we increase the number of things we're looking for, in this case, alterations, we can see we can detect lower and lower amounts. So increasing our threshold of detection by increasing the things we're looking for. And that's led to a lot of development in bioinformatic as well as biochemical techniques to examine the DNA that's in the circulation. And as you can see here, these are several different tumor-specific alterations we can take a look at. Some of them are chromosomal arm losses and gains. We can look at for deletions, amplifications, translocations, sequence alterations as mutations, or fragmentation profiles, which is what I'm going to continue to talk about briefly. And so these all, specifically fragmentation profiles, these, as I would call them, mutation agnostic approaches, do increase the signal to noise in our assessment, because we are able to look at the whole genome and changes throughout the whole genome. We're looking for far more than one change. We're looking at up to thousands of changes per cancer or per patient, and that gives us allows us to increase our detection rate. And one of the characteristics, the fragment size, is both interesting because of the technical features of the sequencing as well as its biological nature. So this is sort of a recapitulation of that previous figure I showed about the amount of how cell-free DNA gets in your blood. But basically, cells are dying and they release DNA into the blood. However, the DNA that is found in the blood is not random. It is related to the binding of proteins such as nucleosomes, the histones in the nucleosomes, as well as transcription factors. And this is evidenced by the length of fragments within the blood that we see. So the peak here is around 166, 167, which is the same distance as it takes to wrap around a nucleosome and go to the next nucleosome. And so there's a high concentration of cell-free DNA in blood that is related to that wrap. But as you can see here, something that's been seen before and evidenced by what we're going to show you briefly is that the distribution of fragment size in healthy patients, patients without cancer is actually very tightly correlated, but patients with cancer, this distribution sort of is less tightly correlated. So you can see differences in blue here with the fragmentation versus the gray, which are the non-cancer patients without cancer. It's very tightly correlated, likely because the cell-free DNA is mostly, if not all, coming from white blood cells. As I mentioned, these mutation agnostic approaches are looking for lots of different changes. And that leads us to lots of different things we have to look at for each individual patient. And that so gives us a lot of data to look at. And in order to deal with all of that data and balance what is important and unimportant, we need to use modern techniques to figure this out. And one of those techniques is machine learning over the whole genome. And that's somewhat central to the bioinformatic approaches that we've been using to detect changes in fragmentation profiles in patients with cancer. And so just to give a brief explainer about what machine learning actually is, so that in this case, we can make a schematic of the information we're getting out of our DNA sequencing. We can see that we could break the genome into multiple regions, and then for each region, we can think of features like change in the length of fragments or change in the ratio of length of fragments, things like that. And for each of these features in each of these regions, we can give it a score. And using a score, all these multiple scores, we can test these scores in patients with cancer and without cancer, and do this iteratively, which is machine learning, to weight the scores appropriately. And this general method was applied in a paper from our group, and with a acronym, of course, the Delphi technique, DNA evaluations of fragments for early interception. Just to show that we took a group of patients with cancer and a group of patients without cancer. And as schematized here, you could see that in patients without cancer, the wrap around the nucleosomes is less variable, while it is more variable here. And this is just a representation of the noisiness of a cancer genome versus a healthy genome. And then we used machine learning to see if we could determine the difference between healthy and cancer, and furthermore, between type of cancer from each other. And in this cohort, we were able to include 26 patients who had known cholangiocarcinoma, and using the Delphi technique to 95% specificity, we had an 88% sensitivity. If we increase the specificity a little bit, it goes down, but we were able to detect most of the patients using this fragmentation approach. And we're not the only group to have done a fragmentation approach looking at cholangiocarcinoma patients. More recently, published in Hepatology, a group was looking at primary liver cancers and was able to identify a subset that had cholangiocarcinoma, and their sensitivities were very high as well with a technique that was a modification of the Delphi technique. So overall, techniques like this provide promise for detection, specifically early detection of cholangiocarcinoma, and it is logical that early detection will lead to increased chance of cure. So where do we go from here? These methods are always continually be refined, and none of the methods that I've showed you actually were trained only on cholangiocarcinoma. So if we were able to get a larger cohort of patients with cholangiocarcinoma, we could perhaps create a model that it's more weighting for cholangiocarcinoma versus other types. Once this is in place, then this could be used in actual screening setting. So all these studies are done with patients with known cholangiocarcinoma, comparing them to patients without. But ideally, we would need to test this in a screening setting, and that you'd want to do that in a high-risk cohort, such as people with PSC. And then these methods are also exportable to using them for treatment monitoring as well after treatment or surgery. With that, I will finish, and I'll be happy to take questions at the Q&A afterwards.
Thank you very much, Dr. Foda, for the great presentation. We will move on for the next speaker, and we will have the question in the end. The next speaker is Dr. Luke Boulter. He's a Cancer Research UK Fellow and PI at the MRC Human Genetics Unit in Edinburgh, and he investigates the role of tissue injury and regeneration in the formation of cancer. The talk today is Bridging the Gap Using Models to Push for a Cholangiocarcinoma Cure. Thank you, Luke, when you want.
Thank you. Can I just check that you can see my screen now? Is that right?
Yes.
Perfect.
Great. So thank you very much for inviting me to speak with you today. And sorry I can't be in Salt Lake City with you. It would have been nice to leave the UK. So I'm going to talk about some of the work we've been doing.
Sorry, Luke, you have also the presentation in the format presentation if you want to change it.
Let me see. Is this better?
Yeah, perfect.
Great.
Now, yes. Thank you.
Thank you. So yes, some of the work we've been doing, looking at really how we can model cholangiocarcinoma and what we can really do to try and use these complex models, both in vitro and in vivo, to develop new therapeutics to treat these tumors. And my lab really works around this kind of framework. And we ask ourselves constantly what a model should look like. And we think a model should really be patient-led, so it should absolutely reflect the patient kind of diseases and the pattern of diseases that we see pathologically. But it should also provide us with cellular and molecular understanding of the disease, such that we can develop both our understanding of the mechanisms of cancer, so really kind of get down to the fundamental biology of this tumor, but also can we then translate those into understanding therapy? So by having this kind of, we think, quite holistic approach, we hope it enables us to define new therapeutic targets beyond what we currently have. And there are lots and lots of models out there. So we do, as a field, lag behind other cancer types. However, there has been a concerted push over the last decade to change this. And really, the models that we can use now go full circle. So 2D cell cultures, 3D tumoroids, tissue slices, xenografts or orthotopic transplantation models, and then more complex genetically engineered mice. And of course, we should always consider the patient as that has the potential to be part of that experimental design, both patient material, but also kind of clinical trials. And I've spoken before about tumoroids, these complex 3D structures that we can grow in vitro that were very much championed by Chiara, who's on this panel, but also tissue slices where biopsies are taken from patients and grown in culture. And so what I thought I would concentrate on a bit more today was really trying to show our work developing some of the animal models that we've been using. And I think there's a real benefit here because they can, not all of the time, but they can represent some of the disease history that's seen within patients, but also this kind of complex multicellularity. One of the issues that we have had, though, is that they don't always reflect human disease, and they certainly in the past haven't reflected the genetic mosaicism that we know exists in cholangiocarcinoma. And so what we wanted to do was kind of address that and develop new tools where we could identify novel molecular targets, and hoped that they would be useful for therapeutic development beyond what we currently know from molecular stratification, so further than IGH mutations and FGFR translocations. And so to do this, we kind of took a multi-system approach, and we published this earlier this year, where we identified just under 100 or so potentially causative mutations in cholangiocarcinoma from about 300 or so patients. And rather than using a frequency-based method, which is the most popular way of identifying mutations in tumors, we decided that what we would do was use this kind of more holistic approach, where we, as well as looking at frequency, looked at the potential impact of these mutations on the genetic sequence. And so this allowed us to identify many more mutations perhaps than previous studies have shown. We did identify our consensus group of mutations, so IDHs, P53, KRAS, things that have come out of other studies. But then we also identified mutations in this kind of long tail, where the mutations are infrequent, so they may only exist in 3% of patients or fewer, but we postulated that these rare mutations actually play a role in the pathogenic process of cholangiocarcinoma formation. So to test that, we put together this model where we adapted tools that were already available in the field. If I'm honest, we didn't really do very much that was very clever. But we built a highly multiplexed Cas9 CRISPR screen. So we can take our candidate mutations that came from our patient data, so this is always referring back to the patient, and we can mutate those genes in the liver directly by using CRISPR genome editing. And sadly, what we found actually was when we just put this library in on its own, we failed to generate any tumors. So whatever's in this library, these loss of function mutations that we introduce, are insufficient to initiate cancer within the time frame that we looked at. But we took this other approach where we screened our library, so all of these loss of function mutations, both known and unknown from patients, against mutations in genes called RAS, so NRAS and KRAS. And KRAS in particular is the most common gain of function mutation we found in our data set. And when we combine this gain of function mutation in KRAS or NRAS with our loss of function library, we generate these very large cholangiocarcinomas within about 8 weeks or so in a number of our animals. And so this said to us that there's something in this, this library, in this kind of loss of function pool, that is able to synergize with the KRAS and NRAS oncogenes in order to initiate and drive tumorigenesis. So this was quite exciting for us. And of course, because this is a mouse, we can do this repeatedly on multiple animals. We can generate these experimental cancers, and it allows us to really understand the biology behind those kind of tumors. And when we take out those tumors and sequence them, what we can find is that, perhaps unsurprisingly, we often delete P53. This is completely unsurprising, actually, because it's the most commonly mutated gene in the whole of cholangiocarcinoma, as well as other cancers. But we also found loss of function mutations in things like BRCA2, NF2, PLK2, other things that could potentially synergize with overexpression of this KRAS mutation, and which together drive tumor formation. And so we took those mutations, or sorry, those tumors, and we can look at their transcriptomes, for example, and we can ask whether whether there are any mutations within those cancers that allow them to segregate. And when you have larger groups of cancers, so in more common cancers, for example, you can do this with patient material quite easily. So you can prioritize different groups of cancer based on their transcriptome profiles, whereas we've always struggled to do that, I think, in cholangiocarcinoma. And what I think we were able to do here was show that there are tumors in our model that segregate away from this kind of normal tumor bulk here in blue and yellow. And so the green dots are things that are separate and so behave in a different way. And what we noticed was that in addition to loss of P53, we always lost this other gene called NF2. And NF2 is mutated in other cancers. It's called neurofibromatosis 2. And this gave us a kind of route in to understanding how rare mutations actually contribute and synergize with more common mutations in order to drive tumor initiation, but also affect the phenotype of those cancers. And what you can see when we kind of distill this down further is that NF2 alone is actually sufficient to initiate tumorigenesis and drive tumor growth. P53 is, of course, but when we combine NF2 and P53, so here in the blue line on the left, the survival of these mice rapidly decreases. So animals really only survive for about a fortnight once tumor initiation has happened, whereas in P53 animals and NF2 animals, that is extended. And this is, we think, due to many, many more tumors forming. So there's something about having an NF2 mutation, which is quite rare, that allows a tumor to escape the normal immune surveillance and suppressive aspects of the immune system. And we can also use these models to understand therapeutic targets. So what we were really interested in was, can we take our really aggressive cancers, so our P53 and NF2 mutant tumors, and identify things that were upregulated in those compared to if you've just lost P53 on its own or you've just lost NF2 on its own. And what we were able to find was this kind of signature of enhanced Wnt and cadherin signaling. And Wnt is a known driver of tumor growth in a lot of tumors. And what's really interesting about cholangiocarcinoma is that actually if we go through the exome sequencing data or whole genome sequencing data, we don't actually find very many mutations in the canonical Wnt signaling pathway. So there aren't any of these kind of gain of function beta-catenin mutations that we see in HCC, or loss of function mutations that we see, in APC, that we see in colorectal cancer. So we've never really been certain how the canonical Wnt signaling pathway is activated in cholangiocarcinomas. And I think this gives us a bit of an example that there are these strange and unusual mechanisms through which Wnt's can be regulated, mainly through these atypical protocadherins. And by losing those in these aggressive cancers, upregulates the Wnt pathway and allows the Wnt activation to drive tumorigenesis. The exciting thing there, I think, is that because you don't have these core mutations in things like APC and beta-catenin, you can start to envisage a strategy where you can give therapeutics that inhibit right at the top of the pathway. So in this case, we were able to inhibit the secretion of Wnt ligands using a compound called LGK974. And that prevents Wnt acting on the cancer cells, and therefore you kind of suppress that pathway. Another set of data showed us that we were also had activated PI3 kinase signaling in these very aggressive tumors. And so we decided that we would do a very naive study where we gave animals cholangiocarcinoma, but then, our really aggressive cholangiocarcinoma, but then could treat them with either a Wnt inhibitor, a PI3 kinase inhibitor, pictilosib, or the two inhibitors together. And both inhibitors work well. They both reduce the mortality of this animal model. But when you combine them together, it really shifts to the left. So I think this demonstrates quite nicely that you can use animal models to understand some therapeutic responses and find new targets for the treatment of cholangiocarcinoma. But one of the strange things that we did find when we were doing this is that whilst there are a number of tumors that have 2 or more mutations and some that have quite a high number of mutations, actually, for many cholangiocarcinoma patients, even with quite a robust method of identifying driver genes or potential driver genes, we found quite a lot that had low mutation rates. So some in which we had no mutations at all, which I don't quite believe, but I think we need to kind of figure out why. And some where mutations were relatively rare. So what is it we're missing in those patients that have a very low mutational burden but still develop tumors? And I think we'll all appreciate that cancer can arise on the background of chronic inflammation, particularly in patients with primary sclerosing cholangitis who have an elevated risk of intrahepatic cholangiocarcinoma, or in parts of Southeast Asia where chronic fluke infection can lead to this kind of iterative biliary regeneration And those patients, of course, also have high levels of intrahepatic cholangiocarcinoma too. So what we're really looking at now is how does inflammation interact with mutagenesis to drive ICC, because we don't think mutagenesis is always sufficient. And so what we've done is developed a new model where we can generate cholangiocarcinoma strictly on the background of inflammation. So these mice have a deletion in P10 and P53 in the bile duct. And over the time course that we've looked at, they fail to generate tumors. However, when you challenge them with this inflammatory agent called thiacetamide, tumors rapidly form, and by 8 weeks, they occupy about a third or so of the liver. And you can see here that at week 6, when we don't have any injury, still we have no tumors. And just as a sanity check, we wanted to know whether those mice that lack P10 and P53, so these inflammatory tumors, also respond to our cocktail of Wnt inhibitor and PI3 kinase inhibitor, so we dosed them. And what we were able to see was a substantial reduction in the amount of tumor that's able to form. So all of these animals, we think, start the same tumorigenic process, but they fail, those tumors in the treatment group fail to progress. And we think this is very exciting and potentially a new route to therapy beyond the current treatment options. And certainly for those patients that don't have a therapeutically actionable mutation, these types of approaches might be quite useful. Just very briefly, one of the things that we're obviously very interested in is this transition early on in cholangiocarcinoma from a healthy duct into an inflamed duct and then into a cancer. And so we've used this model now to start investigating what the earliest moments are of tumor initiation. And we think this is going to be very important for patients, particularly those with a PSC or an underlying inflammatory disease who also develop tumors. And I would encourage you to hang around for later when Ed Jarman from the lab is going to talk about some of the work looking at this. So thank you very much for your time. And I'd like to thank my lab and my funders for all their hard work and for their money. Thank you very much.
Thank you very much. Thank you very much, Luke, and all the speakers for great presentations. Now we will have about 10 minutes questions, and while I encourage all the audience to participate by filling questions in person or through the online system, I will start the question for Juan. Now, in the era of immune oncology, I think we are becoming more familiar that this treatment might benefit remarkably, but just a small group of patients. So do you think that we need to review the endpoints of our clinical trials when we design the trial? I mean, we've seen that the median overall survival sometimes is not enough to capture, this great benefit in a small group. Do you have any thoughts about that?
Yeah, thank you, Chiara. I mean, with any treatment, what we want to try and do is improve overall survival, which is obviously the hardest endpoint that we have. But often we want to have a different endpoint that will give us an indication that we might be able to improve overall survival, so-called surrogate endpoints. And developing a surrogate endpoint really relies on it being validated. So, for example, we know now for chemotherapy, a response rate correlates with overall survival in some cancers. Progression-free survival, in fact, correlates with overall survival better than response rate in chemotherapy trials of biliary tract cancer. But when it comes to novel therapies, which have different mechanisms of action, we might have to think about different endpoints to judge success or failure. And even when we're talking about targeted therapies, we might have a different choice of endpoint, for example, in IDH1 mutated tumors compared to FGFR fusion positive tumors. So I think we pretty much have to go back to the drawing board and work out what are the best surrogate endpoints. At some point, try and persuade regulatory agencies that they correlate with overall survival, because it's really being able to do that would then make sure that we get these treatments approved.
Thank you. Rocio, do we have questions from them?
Yeah, we have questions, please.
Yeah, hi. Am I live? Yeah, thanks. Greg Gores from Mayo. I have two questions. One's for the cell-free DNA talk. You're looking at fragments. I was wondering how you compare the sensitivity and specificity of using the fragment approach versus looking at methylation markers in blood, such as Exact Sciences as reported.
Sure, thank you for the question. Yeah, our methods are similar in terms of sensitivity and specificity. I think the methods are, everyone's constantly improving. And so I think there's growth in both directions. And at some point the assays need to be locked, but I think using all of that epigenetic information is going to be important. The benefit of the fragmentation approach is the ease of sequencing without having to do any sort of modifications beyond library preparation, while methylation requires an extra step, which can increase time and cost. But I think methods that use both likely are going to be the way of the future.
Thanks. And my other question was for Luke. The NF2 mutations activate YAP, and I was wondering if you found other mechanisms to activate YAP by rare mutations in your series.
Thanks for the question, Greg. So we didn't actually, and this was something that we thought was quite surprising and we don't really have an answer for. So when we look for YAP, it is not in the nucleus of cancer cells, it's in the nucleus of cells adjacent to the tumor. And so we think that YAP is doing something there where you have this kind of boundary and there's compression of the parenchymal tissue adjacent to the cancer. And I think that's been described in HCC previously. What we do think is happening is that NF2 is possibly in complex with some of these, or is stabilizing some of these protocoherent junctions, and loss of those is then perpetuating this kind of phenotype.
Okay. Thank you both.
You can go.
Hello, good morning, Jesus Bañales. Congratulations for the nice presentation. My question goes to Luke. First of all, congratulations because the experimental models are very nice, the CRISPR-Cas9. Did you compare the tumor burden of the animals depending on the background of the animals, on the strains? Do they show the same tumor burden, or are there differences according to that? Thank you.
So with our hydrodynamic models, so this is where we've done the CRISPR directly into the liver. The tumor burden seems fairly constant. The biggest factor there seems to be how large the mouse is when you inject it, because I think of plasmid uptake and relative efficiencies of the model. In our transgenic models, so in our classical GEM models, we haven't looked at different backgrounds. So I don't really have an answer to that.
Thank you.
Please.
Juan, this was a very eloquent talk as always. My question is, in your ABC study design, when you talk of a maintenance sort of strategy, that doesn't seem to account for the clinical activity of the drug, doesn't it? For instance, some drugs are cytostatic and may be better in the maintenance setting, and some drugs, for instance, in BRAF V600E, have a 50% response rate. So aren't we sort of lumping them all together in the maintenance strategy because it's possible rather than being attentive to the individual clinical activity of the drug?
Yeah, so the rationale behind that study, thanks Milind, is that we're not able to do an individual comparison for each individual targeted therapy. It's really about taking the general approach of on-target molecular targeted therapy, completely accept that in fact we are lumping them all in together. And I think rather using the pragmatic approach which we've previously used, just to really ask the question whether a molecular targeted therapy approach is the right one to take. We will of course look at some of the detail of each individual subgroup. The numbers are likely to be very, very small, but it may be that specific answer will need to come from other studies.
I have a question from the audience, from online, from Roger Morgan. Sorry? Okay, yeah. From Roger Morgan for Zachariah in the Ctdna. If you had a needle biopsy of the tumor, but the tissue sample was insufficient for testing, is a blood biopsy sufficient, or should you have another tissue biopsy?
Yeah, so I think the answer to that is probably evolving in terms of guiding treatment, if that's the question. There is the ability to detect mutations within the blood, but I don't know of any currently. So in certain cancers, yes, there are some uses of liquid biopsies that have mutation analysis to guide treatment in patients that don't have biopsies. But I think at this stage, we're probably not there yet where we could safely say that if we were going to make decisions based on a biopsy, that a liquid biopsy would be the replacement at this stage. But I think we're heading there soon.
I think the question also lies in the fact that if there is already a biopsy archive, can you use that, or do you have to, as a patient, submit to another biopsy being taken for ctDNA being an approach to follow their treatment?
So I guess if the question, so if there is a biopsy, using tumor information to guide liquid biopsy approaches has been shown to be very helpful. And if the mutation or the genetic changes within the tumor can be detected in the blood, there's no need to re-biopsy the tumor. And so you wouldn't need to sort of redo biopsies or go in that way. But as detection in the blood is an issue, it can be. And so that's something you would like to document before using something to track, I believe.
I think we have time for the last question.
Congrats to all the speakers for very elegant talks. Thanks very much. My question is for Juan. Juan, I want to push you a little bit on FGFR to see what you think would be the best approach. I feel like for the drugs that are already approved, we all know that those phase 3 trials in the front line are really hard to accrue to. They're accruing very slowly, and the front line standard is changing currently changed and may change with the GAP study. So my curiosity is what you think is the way forward for effective targeted therapies like FGFR specifically, the ones that are already approved, like what the plan should be, but especially for the new drugs that are coming in terms of how do you think about randomized trials that are ethical for patients, but also meet the endpoint of efficacy for FDA and EMA approval. If we look at the example of EGFR and ALK inhibitors, usually some of the randomized trials are later generation ALK inhibitors to earlier generation ALK inhibitors, or same for EGFR. Is that the pathway forward that you see, that the new drugs are going to be compared to PEMI and infigratinib? Or like there's so many questions right now in this field. As a major expert in the field, how do you see it going forward?
Thanks, Lipika. I think we probably need to divide here where we're dealing with drugs already in an approved setting. So, for example, when we're thinking about an FGFR inhibitor following chemotherapy, now we have 2 options. We may have 4 options soon in terms of number of drugs. They have slight differences in terms of their mechanism of action, activity, and toxicity profile. But one pragmatic trial, for example, would be to have that decision made randomly through a pragmatic clinical trial. So, we can then get some data on the second line use of an FGFR once we've already decided that we're going to use one. I think it is a bit more challenging when we go into an area where it's off-label. So when we're talking now about a first-line setting, my frustration and I've said.
Uh-oh. Oh, I think in the last minute they are frozen.
It's really necessary. And for example, another approach would have been a pragmatic trial where you just take your FGFR of choice or what's available versus cisplatin gemcitabine, and in fact you can reduce the number of patients that you need to recruit into that study. That, of course, involves lots of collaboration with industry, discussions with regulatory, and so on. So I think it is going to be the rare cancers or even rare subgroups in common cancers that's going to drive this agenda, because the one-size-fits-all phase 3 trial probably isn't going to be feasible.
Thank you.
Okay, now the last one.
I have a question about ctDNA. So in cholangiocarcinoma, I think a lot of patients' fears are reoccurrence because it's so common. And for ctDNA, how early on have you guys seen that fragmentation works to detect a reoccurrence? Have you seen have any data on that?
Yeah, so not specifically in cholangiocarcinoma, but in lung cancer, there's data as well as, I believe, in breast cancer to show that in trials where patients were getting sequential blood draws and sequential CT scans, that in certain cases you can anticipate the imaging change with a blood draw prior to that. And so, yes, that is one of the benefits, either with the mutation agnostic or mutation-based approach that has been seen in these settings. I don't think anybody has shown it for cholangiocarcinoma as of yet, but for other cancers that there's more data on, blood tests can sort of predate the imaging study.
So do you see the future kind of for observance for reoccurrence being like a blood test instead of like intensive imaging, potentially?
I think, yes, as I sort of hinted at the last little bit of the slide there, that yes, I think there's definitely disease monitoring is a very useful place for things like this. I think actually the bar for disease monitoring is slightly lower than for early detection, just because you can have a more expensive test because your sort of likelihood of finding something is higher than of screening a population. So yes, I think disease monitoring is probably going to be more fulfilled as a clinical use than early detection sooner. So yes, I believe so.
Thank you.
So as expected with these panelists, the presentation discussion were fantastic. So thank you very much, all of you, and thank you for the attention and for the participation.
Thank you very much, everyone. Bye-bye.